Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, you know, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Simply an email will get you access to that. I put that together personally, a list of those top 200 drugs, and obviously put in clinical practice pearls as well as some of the most common things you're going to see on board exams and pharmacology exams throughout your career. So definitely worth it. Simply an email will get you access to that, and you can find that free PDF at reallifepharmacology.com. All right, let's get into the drug of the day today, and that is semaglutide. Now, if you are a close listener to the podcast, you'll know that I've covered oral semaglutide previously, particularly closer to when the drug initially came out. But I wanted to spend some time on injectable semaglutide because there are some differences specifically with regard to the indication that it can be used for. So the injectable semaglutide, this is subQ injection given once a week. You can inject it abdominal area, thigh, upper arm, so whatever's most comfortable basically for the patient. In my experience, most are going to do the abdominal injection just for comfort's sake. It's usually the easiest and simplest and potentially least painful as well. This is injectable semaglutide, brand name Ozempic. Now that is the brand name for the dosing that is entailed in type 2 diabetes management. And then there's also a product called Wegovy, which is for weight management or weight loss. So it is important to note with the indications, and this is one of the reasons why I kind of separated semaglutide, and I'm doing it again here. The oral semaglutide does not currently, at least at the time of this podcast, doesn't have the indication for weight loss and the evidence to back it up, where the Wegovy product does have that evidence-based medicine for that indication. So again, type 2 diabetes, weight loss management are going to be the main uses of this medication. Mechanism of action, of course, it is a GLP-1 receptor agonist, which I've covered a few of those in the past. It's going to increase insulin secretion, particularly when blood sugars are high or hyperglycemia is present. So it's what's called a glucose-dependent release of insulin or secretion of insulin. Also reduces excessive glucagon secretion and slows gastric emptying. And, from my experience, my reading, that slowing of the gastric emptying is certainly going to be a helpful component in suppressing that appetite, helping patients feel full, and things of that nature. Now, the dosing, I have seen this come up on pharmacology exams, board exams, those types of things. So the dosing for diabetes, or at least the max dose, is actually less than the max dose for the weight loss product Wegovy. So dosing, we typically are going to start at 0.25 milligrams for 4 weeks, and then we can slowly increase every 4 weeks, and 0.25 up to 0.5, 1, and then 2 milligram is the max recommended dose for type 2 diabetes. With the weight loss product, again, kind of similar process of escalating the dose, 0.25, 0.5, 1 milligram, 1.7, and then the max dose is 2.4 milligrams. Now, with monitoring parameters, obviously you're going to look at blood sugars. Are we bringing them down if we're using this medication for type 2 diabetes? And same thing for weight loss. Are we reducing body weight. That's what our target is. That's what our goal is. For weight loss, most are going to ideally try to target 5% or more reduction in weight, and that's usually over the period of 3 months or so. But again, you're going to want to clinically monitor your patients and make sure that we're actually making progress. And if you're not making progress, after 2-3 months, it makes sense certainly to stop the medication if we're not having any benefit there. All right, let's talk about those adverse drug reactions, and I want to kind of loop this into dosing. GI adverse effects are going to be the most common adverse effect with this agent, and it certainly is dose dependent. So just to give you a few numbers here, so the 2.4 milligram max dose has up to 44% nausea reported, 30% diarrhea, 24% vomiting. So I think what this goes back to is the importance of tapering up slowly and following the dosing schedule with this medication, because at the earliest doses, the lowest doses, the incidence of those adverse effects is obviously much lower, in the single digits as far as the percentage of people that encounter those adverse effects, and then you get up to 44% for the max dose of 2.4 milligrams weekly. For that nausea, diarrhea max 30%, and then vomiting up to 24% for that max dose. So definitely something to pay attention to, something to educate your patients on. Also important that there's interruptions in therapy. So say a patient is gonna go on an extended vacation, or they're gone and they forgot to bring their medication and they quit taking it for a while. Or they experienced an issue, maybe affordability, for example, and they interrupt therapy. In my opinion, it'd be a good idea to probably start back at the original lowest dose and taper back up again. Rather than restarting at a high dose, you're probably going to introduce the risk for those adverse effects to a significant extent there. Okay, let's talk about adverse effects on the rare side of things. So there is a boxed warning in patients for risk of thyroid-related tumors. So that's something to pay attention to. It is contraindicated in those patients, and it's specifically certain types of thyroid cancer and those types of things. So my personal preference in practice, if I know somebody has had thyroid issues, if they've had thyroid cancer in the past, that's certainly a patient I'm going to dig into that background a little bit more and see what the scoop was, and then obviously assess if semaglutide is contraindicated or not. Other rare things that have been reported, pancreatitis. So that's a rare adverse effect. If you've got a patient with a significant history of pancreatitis or maybe multiple episodes, then you're definitely going to have to weigh that risk versus benefit and potentially avoid a GLP-1 agonist here if they have that history, and if we've got other decent options available, which we do tend to have quite a few options now for diabetes management. Other rare things, angioedema, anaphylaxis, injection site reactions. An interesting one that I'm kind of watching is the development of antibodies. So basically, your body can develop antibodies to some of these injectable type medications. And does that really matter clinically? So if you think about what antibodies do, they basically neutralize stuff. And can we have enough antibody production from giving this medication over time and the body reacting to it to alter the way the medication works and basically reduce its efficacy? So evidence is pretty kind of shaky either way, and it's definitely one of those things that I'm kind of following a little bit closely over time as we see these drugs on the market, like semaglutide here, for longer periods of time. Do we see that efficacy wane over time? And I think the jury, in my opinion, the jury's kind of still out on that. But I think it is something to pay attention to as we go on in time here. Monitoring parameters, pretty straightforward. For managing diabetes, certainly we're going to monitor blood sugars, A1C. If patients are not at goal for A1C, we're going to be more aggressive, at least according to the guidelines. We're going to do quarterly monitoring there of A1C. If patients are stable at goal, maybe they're around 7 or a little bit less, and they're right where we want them to be, you're probably only going to do that twice a year. And then, of course, monitoring weight loss. We're going to certainly do that if we're using this medication for that purpose. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're a pharmacist looking for board certification study materials, go support our sponsor, meded101.com/store. We've got a growing list of resources that are updated annually based on guideline changes, new drugs coming out, BCPS, ambulatory care, geriatric certification, BCMTMS, and of course Naplex as well. So go support the sponsor, meded101.com/store. If you're a nurse, PA, other healthcare professional, we've got lots of other resources as well. MedEd 101 Guide to Nursing Pharmacology, very highly rated. People have been incredibly kind in the ratings and reviews that we've received on that book. You can find that on Amazon. Also, Perils of Polypharmacy is a book I put together based upon my experience in geriatrics and some of the challenges in reducing meds, prescribing cascade, and things of that nature. So plenty of resources for everybody. All those links at meded101.com/store. All right, wrapping up with drug interactions. First and foremost, semaglutide being a diabetes agent, we always think about the risk for hypoglycemia, and in general, it's a pretty low risk when semaglutide is used by itself. But when you use sulfonylurea, insulin, drugs that that basically are insulin or stimulate the release of insulin, that's going to increase that risk for hypoglycemia. Nice thing about semaglutide, we don't have any CYP enzyme interactions, so that's great. Other things to think about as far as drug interactions go. One thing I recently saw in practice was DPP-4 inhibitors, such as Januvia, that'd be sitagliptin, used with semaglutide. So again, ADA does not recommend using a GLP-1 with a DPP-4 inhibitor, so I just wanted to remind everybody of that. And if you want an analogy, my best analogy, it would be similar to using an ACE inhibitor with an ARB. These drugs kind of work along the same pathway, and so essentially you're kind of doubling up on what you're trying to do there. So that is not typically recommended to use DPP-4 inhibitor with a GLP-1. And then, of course, I always look out for drugs that raise blood sugars that might counteract any benefits with semaglutide. So corticosteroids are a classic example. If you see somebody on a prednisone burst, that'll likely spike blood sugars and counteract any beneficial effects of semaglutide potentially. And then with weight, I pay attention to that as well. So if I see semaglutide, so brand name product is Wegovy there, being used for weight management purposes, as a pharmacist, it is critical to go through that medication list and make sure we aren't worsening that weight condition. So certain antidepressants, I think of paroxetine, for example, in the SSRI group. That's one of the ones that's probably worst as far as weight gain. Mirtazapine is another antidepressant, not an SSRI, but another antidepressant that tends to be weight positive and cause weight gain. Tricyclic antidepressants, obviously sulfonylureas, insulin, those can increase weight gain and potentially counteract any benefits of semaglutide. And one last one is valproic acid. That is definitely one where I've seen weight gain be an issue there. So again, paying attention from a clinical standpoint, reviewing the list of medications if you've got a patient with significant weight gain where we're thinking about adding a drug like semaglutide for weight loss. your first step should always be to make sure medications aren't causing or contributing to an issue that we're trying to treat. All right, well, that's going to wrap up the podcast for today. I hope you found this beneficial. Please do me a huge favor. Leave me a rating, review on iTunes or wherever you're listening. It's greatly appreciated. Helps us grow the podcast. Shoot an email out to listservs, pharmacy students, healthcare friends, anyone who might benefit from a little pharmacology education. This audience has grown organically, and I'm incredibly grateful with how many people listen to the podcast. It's definitely humbling to know, and helps keep me on task and sharing what I learn as I practice as a clinical pharmacist. If you want to track me down, got suggestions, comments, questions about study materials on MedEd 101, mededucation101 at gmail.com. Otherwise, LinkedIn is probably the platform I'm most active on. So you can find me there, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today, and I thank you all so much for listening.
Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.